from your presentations, if that's okay. We'll hit escape to bring it back at the end for the online audience. Excellent. Well, good morning, everyone, and welcome. I have the pleasure of introducing three speakers this morning, and we have a very exciting lectures that are pending. I would like to begin with the land acknowledgement and acknowledge that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence has nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. And as I do the introductions, I'll do my very best to pronounce the words in Mohawk and also in Algonquin, but I do apologize if there's a slight mispronunciation. Our first speaker is Dr. Radha Jetty, whose passion pervades her life work as a consultant pediatrician. As a physician lead for the Nunavut program in Indigenous child health at CHEO, she's the medical director of the Akuluk Clinic at CHEO, clinical investigator at the CHEO Research Institute, and associate professor at the University of Ottawa. She is dedicated to improving the health and well-being of children, with a particular focus on Indigenous children in Canada and globally. As Nunavut's first full-time pediatrician, she established the territory's pediatric program from 2008 to 2012. Our next speaker will be Kimberly Johnson-Breen, who is a new Canadian Indigenous social worker and Master of Social Work, who specializes in administrative and community practice alongside trauma-informed psychotherapy for families. She supports Inuit family from communities in Nunavut using relational, strength-based approaches that empower self-determination. Kimberly volunteers as the Indigenous Engagement Coordinator within Algonquin communities in Ottawa, grounding her advocacy in the United Nations Declaration on the Rights of Indigenous People and the Truth and Reconciliation Commission's call to action. She's a proud citizen of the Cherokee Nation in Tahlequah, Oklahoma, and a lifetime member of the Phi Alpha Honor Society. And our third speaker is Jade Gabri, who is a Ganeaka Wolf Clan Haudenosaunee woman from Akwesasne. She is a mother, daughter, and wife. As a Haudenosaunee woman, she shares the perspective that caring is for our environment is essential to caring for ourselves and future generations. Jade is an Indigenous registered nurse and ecological activist, having worked in both sectors with Indigenous organizations and communities. She hopes that one day the broader healthcare community will share this relational Indigenous perspective for the betterment of the next 7 generations. So without further ado, I'll turn the floor over to our speakers. Thank you again. I don't know if that's push the button here. I think it's because I should work now. Okay, there you go. All right.
Osta Sonali Nigad, Unega Golana Ageya, Kimberly Dawatoa, Chichalagi, Ani Chalagi, Ani Yawi, Wahia Chuni Yawi. Good morning, everyone. My name is Kimberly White Raven Woman. I am Cherokee from the Cherokee Nation in Tahlequah, Oklahoma. My ancestral clan, because it's matrilineal, but it was my father that was Cherokee. My clan is, ancestral clan is Wolf Clan. If you see the picture on the left, and there's a little picture of Oklahoma, that red part is the reservation that I grew up on in my teenage years. And then in the same left corner is my parents and most of my ancestors and relatives that shaped my life in my formative years as a child. There's my great-grandfather Charlie, who's Shalagi. He's a medicine man, and he was a medicine man that I was raised with. There's my great-grandmother Mary next to him. She was a fierce and amazing woman that I grew up with. She used to make the best meat pies and raisin pies, and she would never tell me what meat she used as she was hunting. But she also told me stories of the Trail of Tears, where her mother, Letha, was little, and how it felt being removed from your lands. And I have many relatives there. One of my favorite pictures is the one with my mother, her mother, my Shalagi grandmother, and some great aunts. And then there's a picture on the right side of my daughter and I, and then my mom's siblings. And that's who I am. And the next, I would like to bring forth Jade. Wado.
Sego, Sewagwego, Welados, Galuhiado, Yungyats, Wagatahuni, Ganyak Gahaga, Akwazasne, Dagidalo. So, hello everybody. I send greetings your way and good morning. So, my name is Galuhiado, or Jade, and my traditional name means she writes in the sky. So, I am from the Akwesasne Mohawk territory. I am Mohawk, part of the Haudenosaunee Confederacy. And the wampum belt actually represents our Haudenosaunee Confederacy or Iroquois Confederacy. So each of the symbols on that Confederacy belt represents a nation. So all of these nations came together to form the Confederacy. To the left here would be the Seneca Nation, followed by Cayuga, Onondaga, Oneida, and then the Mohawk Nation on the eastern door. And if you picture our territory, which runs along New York State and up into Ontario and Quebec, you can see how this long, if you envision it, this long longhouse extends across our territories. And originally our territories even went up into the Great Lakes region. So at the western door, there would be the Seneca people protecting our Confederacy, and then on the eastern portion, it would be the Mohawk people protecting that long house, if you can envision it. And above that wampum belt is our two-row wampum. And pictured in that is two purple lines, and those represent a European ship as well as Haudenosaunee canoe. So this was a relationship building wampum belt that was established between the Dutch and the Haudenosaunee back in the 1600s at first contact. It represents that that will walk along in life along this river, each having our own ways of language, customs, governance, structures, ideals, worldviews, and that we won't interfere with each other. In the same way, we have to look at medicine in this way, understanding that Haudenosaunee people, as well as all Indigenous people, have their own knowledge systems and health and well-being understandings, and that there is a Western model too that exists. But I believe that Indigenous understanding of health and well-being is holistic in that it can encompass Western medicine into it. But Western medicine has a bit to go to bring about that mutual understanding. So Haudenosaunee or Indigenous concepts of healing and well-being can teach the healing power of relationship, the importance of listening without judging or interpreting, the importance of spiritual dimensions for healing, the necessity of community, and our own healing powers from within. So in this image here is my grandmother at the center, as well as my mother, myself, and my daughter. So like Kimberly said, that we are a matrilineal society, and that represents 4 generations of the Wolf Clan being passed down. Below that image is a picture of my family, and then my husband and my little girl. So I will pass it on to Dr. Radha Jetty.
Namaskaram ulukut uvanga Radha Jetty CHEO mi lutanguyunga. As you can see, there is real importance in beginning in a good way and locating ourselves. And I've learned the importance of being clear about the perspective that I bring. So today, I speak as a settler pediatrician and as an ally, and not to speak for Indigenous peoples, but to reflect on my own responsibilities. These have been shaped by what I've learned from Indigenous colleagues, elders, and families over the last 20 years. I'm also a Turtle Island-born daughter of immigrants from India, a country with its own history of colonization. Growing up until this day, I experienced the challenges of holding on to my Indian language, traditions, and identity while navigating racism and othering. And all these experiences have shaped a strong sense of identity and in me and the values that I pass down to my daughter now. I strive to practice with humility and gratitude and to continually examine my own biases, which we're going to talk about today. And I feel very honored to be able to present along my colleagues today who are the true experts. Our Grand Rounds topic today is not an easy one, and it was very challenging for us to put this all together. Conversations about unconscious bias, racism, can feel uncomfortable, can feel confronting, and can also be deeply personal. Yet they are necessary. While universal health care is a foundational Canadian value, unfortunately, it is not the lived reality of many Original peoples of Canada. Racism continues to exist at the level of individual interactions with healthcare providers, and it is also embedded in policies, practices, and structures that we work in. So now the essential question for all of us is how do we recognize it and how do we address it? So today, we invite you to see what you may not have seen. We invite you to sit with discomfort because this is a meaningful starting point for change. And we invite you to be courageous, to examine your own biases and take the necessary actions to create safer spaces for Indigenous children and families at CHEO. So with this, I'll hand it back over to Kimberly.
Although by the end of this session, our hope is that we will be able to understand the magnitude and impact of unconscious bias and racism experienced by Indigenous peoples within the healthcare system. That you can hear and reflect on the lived experiences of Indigenous children and families receiving care at CHEO. That you can examine the history of colonization and the enduring legacy within contemporary healthcare structures and practices. That you will review in your own time the legal, ethical, and professional obligations to provide equitable, culturally safe care. That you will continue to learn about reconciliation initiatives at CHEO and how they aim to improve safety, trust, and outcomes for Indigenous families. And we hope that there will be reflection and that you can reflect on how to recognize and address biases and racism in ourselves, in others, and within the systems we work in. Back to you, Jade.
So before we begin, here are a few pictures of individuals I am sure you all know. So we want to take time to acknowledge Brian Sinclair, Joyce Echequan, and Jordan River Anderson, whose death exposed systemic anti-Indigenous racism, medical neglect, and structural inequities in Canada's healthcare system, sparking national movements for justice, leading to Joyce's Principle, which is a framework calling for equitable and culturally safe care for Indigenous peoples, and Jordan's principle ensuring First Nations children receive the services they need without jurisdictional delays. Their legacies call on us to recognize these injustices and to act with intentions so they are never repeated. Unconscious bias, individual level bias, and system level bias all contributed to the preventable deaths of Joyce Echaquan, Brian Sinclair, and Jordan River Anderson. At times, bias can override stated values, leading to harmful decisions and life-threatening neglect for Indigenous peoples. These three examples are the most well-known, but the magnitude of the problem continues across Canada. Racism is persistent and widespread. In a British Columbia study report in 2020, in plain sight, documented widespread systemic racism in the provincial health system. A 2024 University of Calgary study similarly revealed that 2/3 of Alberta physicians surveyed held implicit anti-Indigenous bias, and many expressed discomfort discussing racism. In Ontario Champlain Region, Share Your Story report released by Wabano Centre for Aboriginal Health and the Ottawa Aboriginal Coalition highlighted pervasive Indigenous-specific racism, where they gathered from more than 300 stories of discriminatory treatment across the local healthcare services. Together, these findings underscore that Indigenous and anti-Indigenous racism in healthcare is not isolated. It's a national, systemic issue requiring urgent and sustained action. And the impact of the problem continues. Racism in healthcare has real and harmful consequences, contributing to poor health outcomes for Indigenous peoples, including higher rates of chronic illness, mental health challenges, and early death. It also leads many to delay or avoid seeking care due to deep mistrust formed through repeated negative experiences. In the Champlain region, the Share Your Story report released by the Wabano Centre and the Ottawa Aboriginal Coalition found that nearly 3/4 of participants said they avoided health professionals to protect themselves from further discrimination. These findings make clear that racism is not abstract. It is a determinant of health, in some cases, a determinant of survival. I will pass it on to Kimberly.
All right, let's see if I can read this. The lived experiences, I cannot see this. The lived experiences, which are the stories of our patients here. This is their stories. These are not necessarily from long ago, but incidences and things that have happened. We have an Indigenous youth brings an eagle feather, and it is taken away from him in case he might harm himself with it. We have an Inuk mother who flips her child to the front or back on her amauti, and the suggestion is let's call CAS. And we have I can't see this, a nurse that overhears and sees a patient in our family that can't, whatever stress is going on inside them, they leave the hospital or they need a moment, and they are labeled as neglectful. CHEO is not immune to systemic racism. These stories illustrate both individual and system-level impacts and how assumptions, policies, and funding structures can profoundly affect care and trust. These practices are often misunderstood or dismissed as non-essential and lead to cultural disconnection, diminished trust, and reduced holistic care. Parents get overwhelmed and need a moment but this can be misread as disinterest or neglect. This leads to mistrust and more trauma. As far as system levels, we have I cannot read this. I'm sorry, it's so small. But I don't have that. The system levels are, Radha, can you come read this?
Oh,
Because I cannot see
yeah,
that well,
sure.
and then I can.
Sure.
Sorry.
So, some examples that, demonstrate system level biases. An Inuit child requiring stem cell transplant in Ottawa cannot access home care, respite, or rehab services because with a Nunavut health card, they're not able to access these Ontario-based services. The second example that we wanted to share with you is a critically ill child from northern Quebec was airlifted alone because policy forbid parents from accompanying them. Another example is a child seen with a foster parent where the parent of origin was not present and decisions were made without the family involvement.
Policies and jurisdictional rules can prevent children from accessing essential services, creating stress and disruption in families and in their life. Children were transported alone via medevac flights, causing emotional trauma for both child and family. Care decisions are sometimes made without parents of origin. This reduces autonomy, raises ethical and legal concerns, and risks care plan misalignment with family values. Children and families experience real harm, from cultural disconnection to medical trauma, family separation, and inequitable access to care. Addressing these issues requires both individual reflection and systemic changes. Back to Radha.
Thank you. We have so much we want to share with you, but we're going to try to do our best to get this all in time. So we've just reviewed a few examples of how individual behaviors and system level practices can unintentionally harm children and families. Next, I'd like to share with you two clinical vignettes, and some of you may have been involved in these cases. Both involve similar ethical dilemmas, but the outcomes differ. So we hope that hearing both these stories will help us explore and understand how small decisions, team dynamics, and institutional systems can either protect or harm families. So as you listen, I ask you to consider, how did individual actions and system policies shape each outcome? Whose voices were centered and whose were missed? And finally, what opportunities for culturally safe, equitable care were recognized or overlooked? And, going over these cases is not at all about assigning blame. It's really about reflecting together, questioning assumptions, and thinking critically about how we can respond differently. So our first story takes us back 7 years. Simeone, we've changed the names, a 2-year-old boy from a remote Nunavut community, spent 2 years in hospital, his entire life, as he was medically fragile. And during this long hospitalization, his parents remained deeply committed, hoping to bring him home one day. And when he was finally medically stable, discharge to his home community was not deemed safe due to his high risk of mortality and limited community resources. I think we've all been involved in these situations. So his parents were presented with two options. Either they relocate to Ottawa or they place Simeone in a medical foster home. Simeone's mother tried to relocate to Ottawa, but quickly she became overwhelmed. With the Nunavut health card, they didn't have access to home care, nursing support, respite support. They experienced housing strain, financial strain, and as well isolation from their family, their community, and their land. Fearing burnout, she was advised to request that her child be placed into medical foster care. And the hope was that it would be temporary. However, 7 years later today, Simeone remains in medical foster care despite significant efforts for reunification. For those of you who may not know, medical foster care is a specialized out-of-home placement for children with complex medical needs. And as you know, many Inuit children that we care for from Nunavut with high medical complexity often have no choice but to enter foster homes in urban centers. It is important to acknowledge that Nunavut pediatricians and clinicians advocate strongly for return to home communities, but are often limited by structural constraints. The Department of Family Services in Nunavut makes efforts to keep families together, and it's also important to acknowledge that when it is unavoidable, foster parents provide extremely compassionate care and strive to maintain connections with the families. However, despite all efforts, Indigenous children are overrepresented in the Canadian foster care system. More than half of the children in foster care are Indigenous, while only 7% of the child population in Canada is Indigenous. So why is this? So a significant part of the problem that many of you may not know is that financial support becomes available only once a child is placed into foster care, rather than providing that financial support as a preventative measure to keep the family together. And then this funding ceases when a child is repatriated back home. So I hope you can see that this sets up a structural bias where funding models can actually incentivize placement of children into the foster care system. Many of us know the impacts on parents and children. For children with disrupted attachment and loss of culture and identity, they're especially at risk when they age out of the system, and we've been dealing with this most recently with a few families. When homelessness, poverty, justice involvement, and poor health become significant challenges. For parents, many of you may not know that the loss of a child to foster care is actually often described as a living death. And this actually becomes very important when we weigh the outcome with the medical risk of death. There was a recent landmark study that was published in The Lancet that found that First Nations mothers face a significantly increased risk of death following child removal. So hopefully it is clear that medical foster care should be the last resort and not the default. Our second story brings us to just this past year. Mickey, again, we've changed the names, a 4-month-old boy from Nunavut, was diagnosed with a life-threatening seizure disorder. Discharge was initially deemed unsafe for the same reasons due to fragility and limited community resources. And again, the options that were presented were relocation to Ottawa or placement into medical foster care. I was consulted in this case, and at first glance, as a team, we looked at this case and it resembled Simeone's dilemma. But this time, as a team, we paused and explicitly acknowledged system-level bias toward foster care placement and family separation. And so we decided that medical foster care would only be considered after all alternatives to keep the family together were exhausted. So what actions were taken? It's hard to summarize more than 6 months in one slide, but I'll do my best. I think to summarize, there was significant multidisciplinary collaboration between CHEO and Nunavut teams, case management nurses, OSNI team members, social and cultural navigators, social workers, and community partners. It was a huge team effort. The medical risk, as I mentioned earlier, was assessed alongside the harms of separation using a trauma-informed and culturally safe approach. And the family's wishes were prioritized. It was clear that connection to family, culture, land, and community were extremely important. And at this point, there was a shared accountability between the CHEO and Nunavut teams. And it was important for us to be part of that process to support comprehensive care planning, preparation of documentation, seizure protocols, advanced directives, ensuring medications and supplies were in place in community before the child was discharged home. We were able to provide emergency contact support for Nunavut providers and families, and extensive training for the parents and caregivers were provided as well. And we made every effort to ensure that interpretation and translation of all materials into Inuktitut was done to ensure the family's understanding. As well, we engaged Ottawa Inuit community organizations and the outpatient services to ensure a transition to home community that was safe. So after a 6-month hospitalization, transition from inpatient to the Nunavut community was coordinated through the CHEO Akaluk Clinic, which I'll tell you a little bit more about later. And Mickey was safely discharged to his home community in Nunavut. So what did we learn from this case? I think it's important to note that work cannot rely solely on frontline providers, and it requires institutional commitment, cross-jurisdictional accountability, standardized processes, continuity of care, administrative support, and investment in culturally safe pathways. Many individuals need to come together to make this happen. And when systems do adapt, rather than default to separation, different outcomes are possible. And as you will hear from Kimberly, colonization is not a closed chapter in Canadian history. Many Indigenous leaders have described the foster care system as the new residential school system. I'll hand it back to Kimberly to speak more about this history of colonization.
When we talk about colonization, this isn't just about the past timeline, as you can see on that slide. It's about how it shapes today. Land was taken. Children were removed from families. Languages and cultures were suppressed. And systemic racism became embedded in institutions. The impact runs deep. Communities lost economic foundations and food systems. Families carry trauma across generations. Trust in state systems is fractured, and supports remain underfunded. These aren't historical wounds. They're lived realities every day for Indigenous families. Hospitals and health systems became tools of colonization. Indigenous peoples were segregated into underfunded Indian hospitals, subjected to medical experimentation, denied informed consent, and often refused care. Language barriers, racism, and assumptions of non-compliance led to misdiagnosis, delayed treatment, and preventable deaths. Families were excluded from care, and children were separated through medical evacuation and institutionalization. Canada ran nutrition experiments on Indigenous children by withholding adequate food to study malnutrition. Medical procedures and drug trials were conducted without consent. Care was delayed or denied to observe outcomes. These weren't accidents or bad judgment calls. They were legal, funded, and justified at the time. That history, that truth, matters when we talk about trust, consent, and fear in hospitals today. Colonization created the conditions that shape health for Indigenous peoples. Poverty, food insecurities, overcrowded housing, and disrupted education aren't personal failings. They are the results of land dispossession, forced relocation, residential schools, and chronic underfunding. Hospitals weren't neutral. They were sites of harm, control, and experimentation. That history lives on in bodies, families, and communities. The health inequities we see today reflect systemic policy, not individual choice. These systems didn't disappear. Indigenous patients still face racism in hospitals, gaps in access to care, medical travel that separates families, and policies that prioritize systems over people. When we see poverty, missed appointments, or fear of care, we're not seeing noncompliance. We're seeing the long reach of colonization. When families enter our care, the question isn't whether history matters, it's whether our systems are ready to take responsibility for it. Social determinants like overcrowding, housing, food insecurities, income and employment barriers, education gaps, and lack of culturally safe healthcare contribute to higher rates of chronic illness, mental health challenges, substance use, child welfare involvement, reduced life expectancies, and ongoing inequities. These outcomes are not accidental. They are the predictable result of colonization. And we have our legal obligations. In Ontario, the Child, Youth, and Family Services Act is binding law. In Nunavut, the Nunavut Child and Family Services Act applies. Alongside this, though, is the federal act respecting First Nations, Inuit, and Métis children, youth, and families. Across these laws, the expectations are consistent. The best interests, protection, and well-being of the child are paramount. Children have the right to be heard and to participate in decisions that affect them. Indigenous identity must be identified and considered. Cultural, family, and community connections must be respected, but mandatory reporting obligations apply to health practitioners. These are not abstract principles. They directly shape how we practice. The Truth and Reconciliation Commissioner's 94 calls to action set clear expectations for institutional accountability. Calls to action 18 through 24 focus on health and explicitly recognize colonism as a determinant of health. They call for cultural safety, anti-racism, and the inclusion of Indigenous healing practices. Reconciliation is not symbolic. It requires structural change in how systems operate. And now I'll give it back to Jade, and she's going to talk about the reconciliation.
So we are all partners in reconciliation, and as healthcare leaders, we must work as allies with Indigenous leaders and experts. So here at CHEO, I specifically represent the Office of I-Ideas, and at the core of the Office of I-Ideas is indigeneity. So we are working on focusing and strengthening Indigenous health equity by building meaningful relationships, creating culturally safe protocols, and offering training like unconscious bias training and Inuit culturally safe care training modules. It also includes marking key commemorative days, addressing Indigenous-related concerns through our safety reporting system, and collecting data through patient surveys and Indigenous staff counts to guide improvements here at CHEO. So, in addition to clinical research, policy work, and specific cultural care that has already taken place, we look forward to these initiatives. So we have a vision for trauma-informed care here at CHEO that we are working on implementing. We also look to hire Indigenous cultural and clinical patient navigators, and this all goes into the safer care framework that we are developing in the Office of I-Ideas, as well as developing an interactive tool for Indigenous engagement tracking where different departments within CHEO can look who's engaging with what Indigenous organizations and partners and kind of collaborate on those engagement pieces. I will pass it on to Radha.
So in addition to the policy initiatives that were described, I really do want to also acknowledge all the work that many of you are involved with: Indigenous-led and collaborative research, undergraduate and postgraduate education with the University of Ottawa, the Royal College, the Canadian Pediatric Society. There are also innovative clinical initiatives. And I did want to just take a moment to talk a little bit about the Nunavut program as one example of reconciliation in action. And because we do see many children from Nunavut on the inpatient wards, in the clinics, it's important for you to know that you can draw on this program for support as well. And it's really through strong partnerships with northern and communities, northern partners and community partners, that environmental scans, surveys of Inuit families and healthcare providers were conducted. All these highlighted a high level of medical and social complexity. And these insights led to the development of the Akaluk Clinic, which I mentioned earlier in 2019. And just very briefly, the clinic was created to provide an interdisciplinary, family-centered, and culturally safe model of care for children and youth from Nunavut who have significant medical and social complexity. And these include children who require temporary relocation to Ottawa, including those who are in medical foster care. The clinic also supports earlier hospital discharge and helps coordinate safe transitions back home, like we saw with Mickey's story. And our vision is to streamline communication across the circle of care, reduce care fragmentation, and hopefully serve as a model for other centers caring for medically complex children from Nunavut. These are some key initiatives through which the Nunavut program and the Akaluk Clinic have provided support. And we hope to continue to identify pressure points and areas where the program and the clinic can continue to support frontline clinical providers. And now that we've reviewed some system-level initiatives, let's take a look at what we can do about our own bias. So I think first it's important to recognize that this work is challenging, especially for frontline staff in very busy, high-stress environments, clinical environments. So the mnemonic self can sometimes help us remember to first slow down, take a moment, pause and reflect, especially during those stressful situations. It's important to empathize with others' perspectives and learn about Indigenous communities in our region. And this point is important, which brings me actually to the importance of Indigenous cultural safety training. And there's significant evidence to show that it's effective, especially when it is reinforced through institutional accountability. Now let's go back to those examples that Kimberly presented, and let's reflect together. So the nurse who overhears colleagues describe a parent as neglectful due to absence at the bedside. So we pause. We ask ourselves, what assumptions am I making about this family? And then we can use a trauma-informed reframe and ask, what happened to you rather than what's wrong with you? For that child seen with the foster parent where the parent of origin was not present and decisions were made without the family involvement, we should pause and ask ourselves, who's missing from this conversation? How might that change our decisions? And then we can ask ourselves what processes are needed to ensure that the legal decision makers are included. And finally, for that example of the Indigenous youth who brings an eagle feather to his appointment and it's taken away due to concerns about self-harm, we can pause and ask, have I asked what cultural supports are important to this family? How can I help ensure those supports are respected and accessible? Who do I call? Here are some resources at CHEO that you may already know about that you can call on for help. And here are some examples of system-level actions. As we mentioned, meaningful change also requires strong institutional commitment and leadership. So the message is clear. First, do no harm. Pause, reflect, act, and ensure the system supports you to do this safely and effectively. We just provided some references here if you'd like to take a look to see evidence for culturally safe care. So the bottom line, bringing this all back to what we talked about, unconscious bias and systemic racism shape Indigenous children's health outcomes. We know that this is rooted in colonization, and it's important to remember that we have a legal and ethical and professional responsibility to provide this equitable care. And reconciliation needs to happen at all levels. And finally, what we choose to see and how we respond directly impacts safety, trust, and well-being.
So to close this, thank you for being here. We want to leave you with this quote from the late Honorable Murray Sinclair. We have described for you a mountain. We have shown you the path to the top. We call upon you to do the climbing. So, thank you.
I thank you all for that presentation. Wonderful and very difficult to wrestle with. There's a lot to unpack, and I really appreciate you all for shining a light on that, and having all of us look inwards and look outwards to try to make the care that we provide better for the Indigenous, Inuit, Métis families and children that we care for. I'll open the floor for questions. I'm just going to stop sharing the bar so that we can see if there's comments or questions in the chat. I think people can see there's some comments there as well. Yeah, please.
So I presume there's efforts that I'm unaware of, to change policies that are harmful to Indigenous families. My question is, what can we do as providers to support those efforts? Because the policy is about transporting a child without their parents, policies around incentivizing foster care in terms of funding, those kind of things.
I'll ask one of our speakers to come forward if they want. And I'll just repeat the question for the online folks while someone's coming forward. Correct me if I'm wrong, Roizen, but the question is, there are policies that are in place that can do harm to the children and families, part of First Nation, Inuit, Métis communities. How can we do better? How can we change those policies to stop that?
That is a huge question. I'll just maybe reflect on an example. So we gave you that example of the evacuation of that child. So that actually was a huge issue a couple of years ago. And some of you may be familiar with a Hand to Hold campaign that Samir Hussein started. He's a pediatrician in Montreal. And he brought this attention. And at the time, I was the chair of the First Nations Inuit Métis Health Committee at the Canadian Pediatric Society. And he brought this issue as, the children are coming down to the Montreal Children's Hospital without a parent. And for years, pediatricians have said this is unethical, this is inappropriate, this needs to change. And so, we really came together as multiple teams, the Canadian Pediatric Society, individual providers. We engaged with organizations, medical organizations across Canada, and we launched a huge campaign to pressure the Quebec government and the EVAC organization to really relook at this policy. And after all those concerted efforts at the individual level, at the systems level, the policy actually changed. And so now the EVAC, the organization, now ensures that there is a caregiver who accompanies their child. So I think every situation is different, but I think it highlights the point that everyone at every level can make a change, but I think it needs to happen in a concerted way. I hope that answers your question.
I would just add that along with that, we are not we are an entity here, we're an organization, but we need to know where we're placed. We need to engage our Indigenous community organizations and listen to what they say. And they need to have a voice at this table for how the policies should look. And we cannot discount that. We actually should acquiesce to our Indigenous community organizations as a whole and do that in the spirit of truth and reconciliation there, because that was the whole point of the TRC, Truth and Reconciliation Commission, and those 94 calls to action, which was Indigenous and non-Indigenous working together and not shirking the truth and doing it in a reconciliatory way. So we cannot do this without our Indigenous community organizations.
Thank you. I see a hand up online. Blaine, I'll ask you to unmute yourself and go ahead with your question or comment, please.
Yes, thank you so much. This has been great. I just want to start by saying what a profound gift it is to have Kim Johnson-Breen at CHEO. I've had the honor of working with her at Wabano, and during that time, she was a very, very strong ally and a very amazing buoy to a very tumultuous time. So the fact that she's here at CHEO is an incredible boon to the organization, to making change. And if there's any hands in the crowd, let's give it to her. I'm so thankful for Jade to be here as well. The more Indigenous folks in these spaces, providing that visual, of Indigenous people actually existing is huge, because we do exist. And oftentimes a lot of our experiences are fictional or unseen. And oftentimes when our realities are unseen, the belief is put on the standard narrative, which is often the Western narrative. So I'm really happy that Kim is here. I'm glad that Jade is here. I'm glad that Dr. Jetty is the ally she is. So my question is, because I do have a question after all that, and I know that from my experience, I do see things as well. What have been some interesting colonial structures within a CHEO-like setting, Kim or Jade, that you feel that are most noticeable? And I don't mean to put you on the spot, so feel free to answer however you want. But what are some things that you may bump into day to day, or things that are glaring that either seem too big or just haven't gotten around to doing addressing yet. Anyway, that's my question.
Thank you, Blaine, for your question. As to some of the most glaring things I see here at CHEO related to colonial structures, I would say the lack of relationships that are built between healthcare providers and Indigenous patients. I believe that healthcare providers are so busy and in the moment and doing their work that, like, from an Indigenous perspective, like, we are based on relationships and getting to know each other, the conversations, and building that kind of basis before building that trust. And I don't think in CHEO and within this healthcare setting that there's time that allows for healthcare providers to do that. So it goes both ways, that it's the system of a hospital and the setting. But yeah, I think that there is that lack of relationship building and knowledge.
Individual accountability
Yes.
or connection to doing that good work from individuals who actually have the power to enact those changes.
Yeah. So
Yeah.
taking that time and actually getting to know the patient, like, where are you from? Like, what are your strengths? What's your community? Like, what's your understanding of health and well-being? Like, what drives you, to have well-being, and what are your supports? So I think that really is a lacking here at CHEO. Kimberly, did you want to add anything there?
I just think as a systemic organization, a hospital, we have a certain amount of imbalance of power when it comes to our children and our families. So that means for us, we have to back up and allow that relationship, as Jade was saying, but how we're not just professionals or medical professionals, but we have to be able to acquiesce to our families in a way. But we also have to look at ourselves as helpers helping our relative, which is where the relationship comes in, as Jade was mentioning. And we do have to be cognizant that this is a system, an organization for help and healing medical, but that we have power, that our families who've come in trauma because they're here because there's a sick child, and that's already traumatic. And if they're Indigenous or they're traveling, there's so much they're bringing through our doors. We have to understand that, which means we have to deliberately back up from that to make it a more balanced.
There's another couple questions in the audience. I think I saw your hand first.
So I know that in UNDRIP and in the federal legislation, self-determination is a key piece, and Indigenous people setting the priorities for what they think a health concern is, and how are you engaging with Indigenous people to set the priority for how to make the systemic changes that you want to make at CHEO?
And I'll just repeat the question. In the federal legislation, self-determination is a key piece. How are we supporting things at CHEO to uphold that and to make the changes? Am I saying that correctly? Feel free to come up if you'd like.
Mostly, but just to make sure that Indigenous peoples could set the priorities about what health issues are a priority for them to fix at CHEO.
How do we help First Nations people to set priorities that matter to them at CHEO?
So hi everyone, it's Vera, and thank you so much, Kim and Jade. Radha. I wasn't able to hear the first part of the presentation, but to me it is about relationships, and it is about the community partners who are the experts. And so some of the ideas that Jade was talking about, where we do need a basis of trauma and violence informed care, the community is telling us that. But it is also the case that the very ideas we have for change need to be supported and informed and developed with community partners. So in my previous work, I made sure that I was developing relationships with the Indigenous-led organizations. And, I think this is what Jade's pointing to. It can't be just leadership or just the iIdeas team. Like, we all need to, whatever work we're doing, be able to have those conversations about, is this going to help? What do you think is needed? But very specifically coming to trying to add more Indigenous positions to the CHEO team. What should those look like? That is the conversation right now. We have draft job descriptions, but what do other partners in the community think will make the most difference? I did also want to pick up on what we've already heard. Again, when I was with Ottawa Public Health, we funded a report that Wabano did called Share Your Stories. There is a lot of information in there. It's a roadmap for how to change the situation. And so I think we don't need to also keep consulting about what to do. We need to follow the roadmap that's been given. But that does mean in ongoing dialogue, in ongoing relationship. Okay, we're trying to do this. We're taking responsibility. Is it making sense? And one key piece I've taken away in my previous practice, and it's very relevant here, is the accountability that you mentioned. We have measures in this hospital today that show us that First Nations, Inuit, Métis, and urban Indigenous people's experience is worse. Right? You shared some case studies, I think, today, but at the population level, we see that. And so we can look at where were those people, where were those families, what was the experience, how do we bring the accountability down to the teams, to the services, to the care providers. So I think that measurement is also what the community is telling us we need to be doing to be able to be accountable and show some change. So for me personally, it is about maintaining the relationships and growing some new ones. So CHEO serves a broader region, and I haven't built personally the relationships with some of the First Nations leaders in First Nations communities. So, this is on our work plan, but it's for all of us. There are many, many resources we can all think about as we cascade our metrics. Like, sometimes we hear about wait times, and we're concerned about wait times. This is a metric that we all need to be concerned about, experience of Indigenous families here. And so I think that strengthening that, making that more visible is one of the priorities for the coming year.
I know there's some extra questions both in the audience and online, but I think just because we are over time, we'll have to close the rounds. But I would encourage people, if you do have questions, please just come forward to ask our speakers. Or if you are online, please feel free to send a message to the speakers, and they may be able to reply to those questions directly through email. But thank you again, Kimberly, Radha, and Jade. Very, very grateful for what you've shared with us today. Thank you.